Talking about acetabular reconstruction and total hip replacement where the acetabulum is abnormal. And I'm going to be talking about a number of conditions. There is quite a lot to cover, so I won't go through every condition in great detail. And that includes DDH of the hip, protrusio, metastatic disease, the post-radiation acetabulum, indications for hip replacements in acetabular fractures, and lastly, hip fusion. Firstly, DDH, total hip replacement is the treatment of choice once you get end-stage degenerative changes after DDH. And but interestingly, when you do hip replacement on these patients, there's a high rate of failure, and that's because of both technical and anatomical abnormalities, and also because it's quite a young patient group. The acetabulum is usually quite flat with a deficient superior, anterior, and lateral wall. And quite often it's a challenge to get the cup into the anatomical position with adequate coverage of the native bone. So the ways around it are to use a small components for the cup, to use an offset bore, which allows you to use a small component and have a thicker polyethylene thickness on the weight-bearing surface, and it also allows you to do some minor adjustments to the center of rotation of the hip. Augmentation, either with implants or bone grafting. You can put the acetabulum in a high hip center, and lastly, medialization of the cup. Pro classification is, I found quite handy because it gives you a guideline as to what to do. It took a while for me to understand it, but it relies on a centered AP pelvis of an AP pelvic X-ray. Firstly, the height of the pelvis is measured, and in situations where you've got quite significant anatomical abnormality of the femoral head, you'd use a fifth of that height as a guide to the height of the femoral head. The other landmark is the interteardrop line and the medial head-neck junction, and it measures the vertical distance between the head-neck junction and the teardrop. The classification is as follows. Pro type 1 is when the hip is subluxed superiorly, less than 50% of the width of the femoral head. Pro type 2, 50 to 75%. Pro 3 is 75 to 100, and Pro type 4 is greater than 100. In Pro type 1, there is really very minimum deformity, and the bone quality is usually very good, so quite often you can get away with conventional implants and a conventional technique. The most difficult cases to treat are the Pro type 2 and 3. And that's mainly because the femoral head is subluxed and applying pressure on the lateral aspect of the acetabulum and becomes eroded. So there's less bone in the acetabulum to support the socket, and placing the socket in the anatomical position, quite often leads to inadequate coverage. So what do you do to as a solution for this? I'll talk about it briefly, but I'll go through in a little bit more detail. Firstly, putting the cup in a high hip center. The advantages are that there's better coverage, there's better bone stock higher up, and it obviates the need for femoral shortening. The disadvantages are that quite often you need a small acetabular component, and it leads to abnormal biomechanics and can lead to early failure. Augmentation, often using the femoral head allograft or autograft, sorry. The advantages are that you put the cup in an anatomical position and it improves bone stock, but the disadvantages are that if quite a significant amount of the cup is being supported by the bone graft, then there is a high risk of the implant failing. Lastly, there's medialization, and that includes intentionally overreaming the medial wall of the native socket, causing a controlled comminuted fracture, a term they call a cotylodysplasty. The advantages of that are you improve the coverage and decrease the joint reaction forces because the cup's in the anatomical position, but obviously the risk of, because of loss of medial wall and catastrophic migration is present in this situation. In Crow type 4, it's actually Crow type 4 hips, because they're further dislocated up the pelvis, it actually preserves the acetabular bone stock. So quite often the acetabulum can be reconstructed in the anatomical position with a smaller component. The technical issues are the fact that quite often, because the head's not in place, the rim's overgrown, there may be soft tissue intervening. Because there hasn't been an articulation in the native acetabulum, the bone's quite often soft, and there is a risk of over-rimming, and the anatomy is often distorted, but you can use internal landmarks to help you place the cup in the correct position, such as the fovea and the teardrop. The second condition I'll go on to talk about now is protrusio acetabuli. Now, for
how do you decide whether it's bone graft or
my understanding is 40%. You can have, well, it should be less than 40% of the cup being uncovered. We're talking mainly about the Crow 2 and Crow 3 reconstruction. Yeah.
To get a good express fit of the animal. Fit, and you can use localized bone. Very thin polyethylene wore out. But better bearing material, you can use bigger diameter. Like more thin. You're going to put the cup higher.
Protrusio acetabuli, the radiographic criteria for it is a center edge angle of Weiberg of greater than 40 degrees. Normally it's around 30 to 35 or less than that. And the medial wall of the acetabulum protrudes beyond the ilioischial line of Kohler by 3 millimeters in male patients and 6 millimeters in the females. Charnley graded that protrusio as mild, moderate, and severe. Mild being less than 5 millimeters, moderate 6 to 15, and severe greater than 15. It's just a diagram. This is the ilioischial line, medial wall of the acetabulum, and for those who set ones, center end angle is the angle between the center of the femoral head and the edge of the acetabular roof laterally. Normally, with protrusio, the axis of migration is 65 degrees to the horizontal, which corresponds to the joint reaction force on the hip. So the hip normally displaces superior and medial. Etiology, there's many secondary causes of protrusio, and primary protrusio is really uncommon, and it's actually a diagnosis of exclusion. It occurs in about 15% of patients with rheumatoid inflammatory arthritis and 33% of patients with ankylosing spondylitis. There are a number of secondary causes, and that's a list that I've got from one of the review papers. Inflammatory causes, rheumatoid arthritis and ankylosing spondylitis is common. Obviously, neoplastic lesions in the acetabulum can cause weakness of the wall and cause protrusio. Infection, in the past TB, strep and staph can cause it. Metabolic conditions such as Paget's disease can cause protrusio. Obviously, post-traumatic and any connective tissue disorders, or a lot of connective tissue disorders can cause it, such as Marfan's. The management really, before the development of degenerative changes of the hip, is to treat the underlying cause of protrusio. And in patients who are picked up and are skeletally mature, the treatment options are to fuse a triradiate cartilage and do a valgizing intertrochanteric osteotomy. In the adolescent or young adults, you can get reasonably good results if there's no degenerative changes with valgizing intertrochanteric osteotomy. But once degenerative changes set in, then the treatment of choice is to do a total hip replacement. With regards to the acetabular reconstruction, it's important to try and put the cup in an anatomical position. Runawat in 1980 looked at acetabular reconstruction in 35 patients with protrusio who had rheumatoid arthritis. It was cemented total hip replacements, both cup and soft and femur. 44 years of follow-up, and it found that in 17 patients in which the cup was placed greater than 10 millimeters from the anatomical center had a high failure rate, whereas those that were placed close to the anatomical center had no failure rate. And they devised a technique of trying to determine where the anatomical position of the cup should be. And this is one of the images from the paper. There's quite a lot of distortion, especially the bilateral protrusio. It's very hard to determine where the cup should be. But the technique basically measures the height of the pelvis, as we do in the Crow classification. Take a fifth of that as the height of the acetabulum, the vertical height. There are two landmarks, the Kohler's line, the ilioischial line, and the Shenton's line. Where it intersects, the starting point is 5 millimeters lateral to that. Going perpendicular to this horizontal line, up 1/5 of the height of the pelvis, and then from there going the same amount across, forming an isosceles triangle, and that's the anatomical location of where the hip should be with the reconstruction. So with regards to the degree of protrusio, in patients with mild protrusio less than 5 millimeters, you can essentially perform a normal conventional total hip replacement where the protrusion is more than 5 millimeters but the medial wall is intact. Using morselized bone graft, either allograft or autograft, is acceptable. It shows quite good incorporation. And another option is to take the femoral head and shape it into a concave convex graft and put it in immediately. Those situations where there is also a medial wall defect, then in addition to bone grafting, you need to augment the fixation with screws, cages, or an anti-protrusio ring. The technical considerations on doing hip replacements in patients with protrusio, firstly, is that the jump distance of the femoral head is going to be increased, and quite often can be difficult to dislocate. A way around it is to do an in situ femoral neck osteotomy or to do a trochanteric osteotomy.